Hello. Today, our interview is going to be regarding a very interesting and unfamiliar topic of palliative care medicine. We have two very prominent physicians that are active in the palliative care world that are going to discuss how to utilize this resource to improve the quality of your life as you go through treatment. Most people will assume that palliative care implies that they are at the end of their life, and it is far from that. It's the way to live your life in a productive manner with a chronic disease. It's not just offered to cancer patients, it's offered to people with any kind of chronic illness that needs help, and we're going to talk about that today. My two guests are going to be Dr. Takeshi Uemura, who is an assistant professor of palliative care and geriatrics at the Würzburg Palliative Care Institute, which is part of Mount Sinai Medical School in New York. And our second guest is Dr. Christopher Woodrell, who is an assistant professor of geriatric and palliative medicine, again at the Würzburg Palliative Care Institute at Mount Sinai Hospital. But he also is a staff physician doing research and education and clinical application at the VA. And I think it's important that Dr. Woodrell should be recognized for the excellent book that he's written called Evidence-Based Practice of Palliative Care. His design has been to go through not just cancer, but multiple chronic illnesses and provide real life applications of the concepts that we're going to talk about today. It's primarily a textbook for physicians, and I think we will review today, but it's really important that more people in the primary care field have an opportunity to learn how to manage this. There just aren't enough fellowships and enough palliative care physicians in the country to manage the need. And it's important that each specialty that's involved with taking care of chronically ill patients and cancer should know how to manage pain medication. How do they manage ancillary help that can be brought in? How do you help people find the most appropriate ways for them to care for themselves and to help the family understand what they can be doing? It's a very complex relationship and really requires expertise. This expertise can be taught, and these two physicians will talk to us about what they do and also provide some resources that you as patients, family, or even physicians can go to be able to get more education and more information. So we'll move ahead with the interview. I think this is open-ended. I think, I put down a couple things I was going to ask about, but I would ask one of you to actually define what palliative care actually means, because as a primary care doctor, when you mention that, people think they're dying and they have nothing left to offer, and they're getting put in this situation where they don't have any more time left.
So it's specialized care for people with serious illnesses that can be at any stage of a serious illness and for somebody of any age, across the lifespan. One of the key components of palliative care is that it's interprofessional. So it's different types of professionals delivering the care, and focuses on relieving the stress of that serious illness for the person and also their family or the people that are important to them. Just briefly, the ways that can be accomplished would be treating symptoms, helping promote coping with the serious illness, helping make sure people have the information they want and need, strategizing how to navigate the health system, and making sure we elicit as many resources as possible to provide support. And I think one common misperception that you alluded to just now is that it in some way replaces the other care, whether that's from their primary care doctor, practitioner, or their specialist that they're seeing. But palliative care is really meant to complement the care that they're receiving from the other teams, and can, in an ideal setting, really work synergistically.
I would think so. As a primary care or an internal medicine person, you don't have time in
Yeah.
your office these days to really sit down with someone. So do you think that the palliative care physician is the navigator and is helping direct patients where they need to, like you mentioned in your book, it's very important that this is not just a medical model, but it's a functional model and a spiritual model and a family model. So when you see someone, how long do you spend initially to decide what the overall picture is that they need?
Good question.
Right, yeah. If you're talking about outpatients, I believe in our outpatient, I mean, I do mainly inpatient, but as far as I know, the new patient normally have 1 hour. Yeah. So 1 hour slot, follow-up normally 30 minutes. Yeah, and then as you said, so the primary care or, for example, oncologist. I believe you're oncologist also?
No,
Oh, you're not oncologist.
no, I'm a primary care physician.
Oh, primary care, got it, got it. But for example, cancer patient, and then there's an oncologist, and that they have, so many things to address, chemotherapy, tumor marker, and then they have no time to deal with the symptom. I mean, they might have, but not enough time to address the symptom or psychosocial aspect. So that's why we're here to complement so that they can focus, for example, cancer patient, cancer care during the oncologist visit so that we got other aspects. Same for, we have COPD patient, we have heart failure patients, but we mainly focus on the other, symptom and the psychosocial aspect. And then we are not only the physician, but also we do have, even in the clinic, spiritual, counselor and the social worker or any other resources so that we can provide comprehensive care.
I
Yeah.
would bet though that in a lot of, except for urban areas, and even in urban areas, I noticed in your new book, Christopher, on palliative care, how many fellows were involved in writing material. And yet I would imagine the number of fellows or trained people to actually do this is very limited in the United States. You're kind of left with a lot of situations where if you have an advantage where you are, where people can see a person that's been trained in this, but there's an awful lot of places where, as a primary care doc, if I can't find someone, I'm kind of flying by the seat of my pants and trying to establish all these negotiations. So it's a very difficult situation right now.
Yeah, definitely. I would say that as an academic palliative care program that we are both in, one of the core goals of the department is to train, right, the next generation of, in our case, it's majority physicians who are being trained to become palliative care specialists. But as you point out, we're not going to reach everyone that is in need, whether you're talking about your people in urban areas or less densely populated areas. So there's a sort of another aim of our field is to bolster the educational content for other types of practicing clinicians, to make sure people get enough of the information about doing this work that they can, within reason, manage it in their practice. And so, and oncology is a great example. Oncologists do the stuff we do all the time, but with their time constraints. And then if things get, past maybe their comfort level or what they're more commonly dealing with, that's when they'll pull in a specialist and ask the person to, that they want to refer them to someone else.
I can see where in a hospital setting, you can be consulted and be able to connect up. In an outpatient setting, I think it's a little more difficult to actually track that down and be able to set it up.
I would say the most successful, I think, or the ideal model is what we would call co-location or embedded models, where you're in the same space practicing. And that's where you get the, like, you know, literally swivel the chair around and have a conversation in real time. But obviously that's not realistic in all settings. So there's what I just described, which we call primary palliative care skills, the palliative care that anyone does, not necessarily referring to a specialty team. But then also there's increased, you know, COVID changed the world in terms of our practice of using virtual visits.
Absolutely.
And actually, there's just a big study coming out from one of the major research groups in our field at Massachusetts General Hospital that they were able to show non-inferiority of their telemedicine visits to the in-person visits.
It can be relatively useful in terms of getting a lot of raw data from patients and what they need, and you know, I think that's the most important thing. Do you tend to like to do this in a family setting, so the patients that are kind of going, oh no, I'm fine, I don't need anything, and then you talk to their significant other and it's like, well, they can't get out of bed because they're in so much pain, or they need help with this. So it seems like you're overall there's a movement towards making this a very, it's not always family, but it's certainly an involvement with the other people in your lives that can help you.
Yeah, absolutely. In our outpatient practice, we find that a lot of family members come to the visits and are there and can be helpful. And also we can be helpful to them. You know, family, caregiver, care partner support is definitely part of our mission as well. You know, assessing their needs and their experience and making suggestions to how to help improve their experience with caring for their family member.
I would bet a lot of physicians aren't aware that this is even available. You know, they've been doing it on their own. I mean, I kind of felt like that's what happened. I started taking care of cancer patients after their chemotherapy and realizing that they hadn't really gotten what they needed. There's also another area that sounds like it's very important. Takeshi, maybe you could talk about the geriatric side. It seems like it's a whole different flavor of, it's one thing to have a 40-year-old that's dealing with, let's say, a non-Hodgkin's lymphoma or Hodgkin's, but it's another thing when you get into the 60s and 70s and 80s. How do you approach those people differently?
In terms of the palliative care perspective, but with the geriatrics.
Yeah, I think the geriatric perspective is important because these days there's so many isolated older patients that really are left out of the system.
Yeah. So my understanding, I mean, geriatric and palliative medicine, there are a lot of overlap as well. And then, yeah, as a geriatrician, and then that's why we in Mount Sinai actually developed this integrated fellowship. So I did the fellowship where they do both at the same time. So I did the geriatric and the palliative medicine at the same time. And then that's why even the geriatric program, normal fellowship program, they're required to do palliative care. I believe at least 4 weeks, if I'm not mistaken. But so it's essential part. But normally in geriatrics, we may see the patient a little bit more upstream, meaning the palliative care have, you know, serious illness, meaning the high risk of mortality, you know, death, basically. Doesn't have to be in 6 months, and then that'll be, you know, like a hospice, but it could be years, 2 years, but more like a geriatrics is deal with the frailty or multiple chronic conditions. So, and then the common thing with the geriatric and palliative medicine is the forward thinking, I would say, meaning prevention. For example, especially geriatrics, we try to prevent falls or prevent readmission. In medicine, I was trained in medicine. In medicine, usually you need diagnosis. And then we have diagnosis, pneumonia, okay, we can treat with the antibiotics. But with the geriatrics, we try to prevent, and then we don't, and then, yeah, and then that's the difference. And then always try to look IGT approach, meaning the psychosocial aspect as well. So there are common things, but geriatrics a little bit more upstream, I would say. But that helps us, especially when we are dealing with the non-cancer diagnosis, for example, heart failure. When I was seeing, so actually I was working in hospice before coming here. I was in hospice, and then we are providing also home-based palliative care as well from the hospice agency. And I was seeing the heart failure patient. They don't have much like a pain or symptoms, but they become debilitated, confined to home, high risk of falls. They're needing the walker, but they don't have, like an appropriate walker, or they don't take medicine appropriate. They have dementia, stuff like that. And then actually the having this geriatric lens when I see this patient actually helped a lot to identify problems, and then so that we can prevent some like a crisis. So definitely there overlap, and then yeah.
Well, when you look at people, they say that people on Medicare now over 65, most of them take half a dozen medications at least. So you're dealing with a whole population that by the time they reach my age, they're actually, in a lot of cases, already in need of some form of palliative care. And so geriatrics and palliative care seem to go together very well as part of, if you're a geriatrician, you should be doing palliative care and vice versa in that realm.
Mhm.
And so it's almost that most of us that are dealing with the elderly people should be required to actually do some continuing education and actually understand better. I mean, Chris, reading your book, even understand, people don't understand. I mean, these days, when you bring up the concept of a narcotic, everybody freaks out about overdoses. And yet in palliative care, it's probably one of the more important features. And the nuances of being able to treat people appropriately comes down to a huge amount of information and knowledge to really do it the correct way. Could you talk one of you talk about how people in palliative care use narcotics as opposed to, oh, you broke your leg, here's 20 Percocet, come back if you have a problem?
Yeah, great question. The first thing I'll say is, the toolbox for pain management is not unlimited. And so, and opioid medications are in many cases, the mainstay of our management, particularly in the case of cancer pain that's severe. And so a lot of our patients are taking opioid medications more long-term than your average population. We focus very much on risk reduction as well. We don't want to, we want to make sure people take them safely, adjust them, work as a team with them to adjust them appropriately, minimizing the harm of potential side effects, whether that's, worrying about sedation or someone who has risk of delirium or someone who's older and might fall, or frankly, the most common side effect is constipation, which can be just awful. So we work with people very closely to make sure we mitigate those side effects to the extent we can. We use other modalities wherever we can. Some medications we can combine to sort of have a synergistic effect with the opioids. Sometimes just regular old acetaminophen can be really, really effective. If there's pain related to maybe a cancer lesion, a mass, that we can, collaborate with their oncology team to think about making sure that gets treated in a way that will reduce their pain.
Is it the palliative care doctor, or is it the primary person that's providing the narcotics? Because that can get to be a little.
Oh, good question. It depends. We do it both ways. There's the consultative model, which is more, well, I guess they're both consultative. There's the model where somebody asks us advice and then we give a recommendation, but then they prescribe it, is one model. But more commonly, people refer out to us, they come to our practice, we write the prescription, we take that on. And one of the reasons I like, the co-located or embedded practice is a nice model, is because then the person being treated or their family member don't have to be like, wait, who am I going to call about, the self triage, right? Like figure out who they're going to call, rather than just saying, oh, I call the center and they'll get the message to the right person.
Yeah.
Because it sounds trivial, but I think for some of these folks, the navigation can be really overwhelming. And that's where things fall through the crack when you don't call the wrong person, you miss an appointment here, you can't get there. So yeah, we do prescribing in a lot of cases.
Also, knowing the patient, if they call a center, that they're not necessarily drug seeking. It's, you call in primary care, you get a lot of calls from people that, well, my back is hurting again. Can you write me a script or send it over? In your situation, you're dealing with people that this is a necessity for a lot of them. I saw that 2/3 of patients in cancer, active treatment or with metastatic disease, have chronic significant pain. So I would imagine most of the people that are being treated in active cancer care are going to need someone to help manage their pain as a predominant thing, especially since, from my experience, if you have a lot of pain, it really does interfere with your longevity. I think people don't cope well not being able to function. And it sounds like from Dr. Uemura, what you said is you want to keep people functional. You want to keep them having and you could maybe address all of this. You want them to have an optimism that even though they're in treatment, they can still have a quality of life that allows them to enjoy their family and do various things. I mean, that's what I think people give up on. They think they're at the end and they stop really caring, which is a real dangerous time to be in. So when you see them, I assume you try to help them understand that what you're doing is to make it better rather than just keep them plateaued and not do very much.
That's right. Yeah. So because we use a lot of medication that has significant potential side effects, especially sedation, fall, delirium, things like that. So, of course, we want to be very careful and then find the fine balance. But sometimes there are moments that we like a sedation might be inevitable, like unavoidable. In this situation, one of the important things we have to do is to clarify goals. So one of the things palliative care does is goals of care conversation or advanced care planning. There are many different names. But I think that clarifying the goals is important, and then we do often. And then meaning, so what's important for them, and also they need to understand what the trajectory, what's the prognosis, what's the timeline we're discussing. And then we ask them what's important, and then ideally we can make recommendation once we know what's important, rather than just to let them choose. Here's the choice A and here's the choice B. You're the one who choose. We don't take this approach. Ideally, in ideal situation, we work together and then we think about what makes most sense. And then we sometimes make even recommendation.
Well, I assume there's times where you have to talk to people about they can't live independently anymore. And do you have, you shouldn't be driving.
Right.
Or and do you probably have to advise them also about some of the legal issues of do you have your resuscitation? Do you have your will? Do you have all things so that your family's protected in terms of what's going on? It sounds like you see that a lot, Chris.
Yeah, we do. We really do. And I think one of the most important interventions we can do, even without going deep into the weeds talking about, you know, prognosis and stuff like that, is just to say, who's the person you would want to be your voice if you can't speak for yourself? We should all have that, ideally, because it's very state by state how it works, but generally speaking, in the United States, it's going to go by your legal/biological family, you know, who's closest sort of down the hierarchy. And that's not always who people want. Um, uh, you know, we've seen really difficult situations where an estranged family member is brought in to be the decision maker when that, you know, the person who's not able to speak for themselves wouldn't want that person, but that's what it is. So that's an important point of self sort of advocacy. And then the other thing I would just add to what we were saying about quality of life before, and I thought, you know, the idea of quality of life is, we think of it, I think it's quite subjective, and we spend actually quite a bit of time and effort helping people think through, like, what are the things that give you a better quality of life? Because people prioritize things differently. And just getting a sense of what they really value, that helps in that conversation that Takeshi was mentioning, you know, sort of hearing what's important and then making a treatment recommendation based on that. So I'll just add that subjective nature.
But it sounds like you have to ask those questions. They don't just, the patient doesn't necessarily know what to ask, and part of what you do
Totally.
is bring that to the forefront.
Totally. And a lot of this stuff, I think not everyone thinks of. I mean, we're both physicians, you know, on a palliative care team, but a lot of people don't necessarily, sometimes they're surprised to hear us ask about some of this stuff.
Mhm.
Because it's not what you might expect to be asked about in a medical setting.
Really?
So, like,
Mhm.
tell us about, you know, what a good day looks like. Tell us about life before you got this diagnosis. Tell us who's important in your life.
Yeah.
Or to the family member, tell us about this person as a person. What are they like? You know,
Mhm.
introduce us to them.
Well, it sounds like it's actually working on a model that fundamentally goes back to individuality for the patient.
Mhm.
And it's not that you really have the time to spend with people. It's not your 10 minutes is up. You actually have designed what you do to incorporate the time needed to take care of the patient.
Yeah. And we're able to complement the enormous healthcare system that's, you know, just so many people coming through. It's a system, right? And one of the reasons I like this job a lot is that we're able to, like, look for the places where we can help, like where are the gaps.
And is this something that health insurance will help with, or is this going to be something that most people have to? Okay.
Yeah,
So
it's definitely covered. You know, I think if someone's making an appointment, they should always double check, you know, make sure they're not going to get sent a bill that they're not expecting. But most offices should be checking that beforehand. And some people have a copay sometimes, just like any other
Sure.
office. But
Now, if patients that are listening to this, if they contacted the Hartsburg Palliative Care Institute, could they arrange to do at least a family member or a person have a virtual consult to talk about where to go, maybe make recommendations on how to get those people to someone where they live that could help them out?
so just a couple quick notes about that. We do virtual visits, but we generally have people come in person the first time, and part of that is because of the rules from CMS about prescribing and everything.
Sure.
And also we can only see people virtually who are in a state where each of us is licensed.
Okay.
And so that is actually a limitation. That there was a period during COVID where some of those restrictions
Right.
were realized, but unfortunately the licensing issue can be a barrier to what could be really great access for people in more remote areas. That said, anyone can call up our office and make an appointment. There is actually a New York State law that if anyone has the right to request palliative care and have it provided. So that I think so that it's not sort of kept from people, if someone, so I would say that for people listening, if there's any sort of distress that you feel like it's not being, that's remaining unaddressed as you're going through your experience with an illness, you can always ask for a referral. And if it's not something you need long-term, then that'll be a one-time visit and maybe you'll come back another time. And other people will continue to come very regularly. It just depends on the person.
Okay. Now, with qualified practitioners, do you find that any kind of integrative care has value for these people and perhaps you could talk a little bit about what you recommend or what you've seen as being effective in this field?
Very much so. Complementary and integrative therapies are something that can be of benefit depending on, the person and their situation. It also depends on what resources are available. If you're in, we're very fortunate to be in a program that has arts-based therapy program that includes music and drama and dance movement therapy. We also have a nurse who's also a yoga can do yoga therapy, and then we have a massage therapist. So there are a number of complementary therapies that can be really beneficial, but as you might imagine, they're not excuse me, they're not universally available.
Right.
So in an ideal model, those folks, and for instance, a lot of the large centers like a cancer center will have those therapies like those available. And we're fortunate in our program in Mount Sinai to have that.
It's interesting that when you're dealing with these days at least, dealing with the situation you're in, being in a medical center and having an institute is different because most oncologists now are privately owned by some form of business. So it really does, it's not a profit-making part of their game plan. So a lot of these people, it's strictly time in, you get your oncology, and then people are off looking for what else they could be doing. But I think it's interesting that you're finding ways to get people into things that will give them some joy. Doing art, doing music helps bring something to them that they can really have a benefit from, and it gets them out of the house and it gets them to interact with other people, which I think becomes very important.
Yeah.
There are people in our field who are very savvy about the health system and the business case for various practices, and I think we always need more research to help build the case, to show what we can actually do for people, and that evidence base is definitely growing, to show that people who end up getting palliative care may have better quality of life that they report. They may be spending more days outside of the hospital than inside the hospital. When we're talking about a paying for these services, I think there's some very smart people working on how to make those cases that are less obvious than like physicians or nurse practitioners billing. In other words, how do you show that when you have a robust social work support on your palliative care team, that it functions better, or robust social work support in your oncology practice? And you have to look for other ways to demonstrate that value. Perhaps it's decreased missed visits. Perhaps it's the oncologist being able to spend more time practicing oncology rather than focusing on some of the other issues. It just, I think it's harder to make the case, but there's definitely ways to make the case for the non-billing.
just looking at the areas you cover, if someone is functionally better and protected, and they're not getting delirium from their pain meds or other problems, you're saving a huge amount of money so that they're not rushing to the ER and they're not ending up getting hospitalized because nobody knows what to do. It's a very common thing that happens in that regard. And
Yeah.
your book is evidence-based. So
Yeah.
when we put this up on the website, I will send you a copy, but I want to put on there the name of the book and what you have to offer, because I think that, there are, we're getting a lot of physicians that are looking at it. And I think anything that's evidence-based these days really goes a long way to justify saying to your patient, I've read this article and these people can justify why we're doing this. So there's a reason that I'm doing this for you. It's not like I just, I'm basing it on what other people have done, which I think is very important.
Yeah, definitely.
Any other areas that we haven't covered?
I was just going to add, Takeshi, you mentioned hospice before, so I wonder if we should just quickly make a note about what hospice is.
That would be terrific.
Sure. Yes. So the hospice is I would say, so the palliative care is a big umbrella, and the hospice is part of palliative care. But originally the hospice is the origin, and then we expanded to palliative care. So that's the other way actually. But now we have both. So hospice is so what the hospice does is actually palliative care. But especially in this country, so many, different country has different systems, my understanding is. But in the United States, it's mainly, covered by Medicare. But not only Medicare, because, some young people also can go to hospice, but mainly Medicare. So it's like an insurance, like a services that develop over time. And then mainly restricted to patient who has prognosis less than 6 months. Okay. So, and then when the people hear the word of hospice, they typically imagine that there is like hospice, like a place, and then they go to hospice. However, in this country particularly, main service is provided at home, the patient's home. And then the hospice team will come to home and then provide. And then the goal is to improve the quality of life as much as possible, meaning the patient can stay home as long as possible, as comfortable as possible. So they do symptom management. And then the big help for the family is that they can access to hospice team 24/7 over the phone. Talk to human, not the AI or machine, like answering service. So they can get advice, for example, oh, my husband is having pain right now, what do I do? And then they normally provide also medicine at home. They can keep the home, the necessary medication, so that they will give advice, okay, please give this amount to your husband, and then let me know how it goes, like 30 minutes later or so that they don't have to call 911. That's the whole purpose, so that they can stay home, they can enjoy time at home, and then the goal is to stay home until the end. Yeah.
There's also assisted living. I mean, if you're in a nursing home,
that's correct,
and you're really sick, you're not going to be able to stay in independent care. You get moved into assisted care, and then I assume they can still bring you to see your doctors at the hospital, and you still can get advice and help by coming from wherever you're living to get palliative care.
For palliative care, yes. One important distinction with hospice is that, generally speaking, when we define palliative care at the beginning, I made a big point of saying this is instead of your care, it's in addition to your care. Right? It complements the care you're getting. Hospice is a little different. In most cases, people forego their disease-directed treatment to really just focus on their symptoms, and no longer, for cancer is a good example, they're not going to be receiving systemic cancer therapy anymore. Instead, it's switching to hospice. So that, as opposed to palliative care, which, they all go together, hospice really is a big switch in terms of what your goals are, what you're trying to achieve.
Someone's moved from palliative care to hospice care, it's more than likely it will be the hospice people taking care of them rather than.
Yes, and those are
That is right.
individual agencies
Mhm.
that are generally local.
Mhm.
And it's usually in the home, like Takeshi said, and but can be delivered in nursing homes.
That's
And then
right.
there are some hospice facilities. They're usually short-term stay,
Mhm.
but not always. They exist. There's hospice homes. Um, this is another area where something sometimes differs geographically. It depends on your local area.
You tend to have medical residents want to come and spend time at, at the Palliative Care Institute to learn more, or is it something that is still being worked on to get them to have the availability?
Where to get the palliative care training?
If you have months that you can choose electives, do you get people that want to come and
Yeah, we
more?
do have a lot of trainees and I mean in Mount Sinai system here. We all the time I have now a psychiatric resident actually rotating with me.
Okay.
We do have of course fellow and also about the primary party. So again, we will never have enough palliative care and then geriatrician in this country to
Right.
see all the older adults and all the serious illness patients. So in Mount Sinai as a pioneer to integrate palliative care and then geriatric education into medical school education.
Oh,
So they're required actually to rotate with us. I believe 3 weeks right now. Is
I
that
think
correct?
so.
Yeah,
Something.
3 weeks.
Sorry.
Yeah, they rotated with us. Also, I was in other institution, medical school, and also that medical school also was requiring the medical student to rotate,
Yeah.
and geriatric and also a little bit of palliative care as well. So some of the medical school is trying to integrate, but still it's not all of them. But it's very important, and always the student appreciate, oh, I didn't know. So it makes huge difference actually, especially when they become physician. They know now when to call specialist palliative care, or they might be a little bit comfortable to talk about difficult things or pain management as well. So it makes huge difference.
I would actually just add, we get emergency medicine residents rotating with us. We get hematology, oncology fellows rotating with us, internal medicine,
ICU.
ICU fellows. Yeah, we get
Yeah.
a lot of folks. And actually, you didn't ask about this, but I'll just add, it's kind of exciting because we have increasingly people from the non-internal medicine and non-family medicine specialties,
Surgery. We do have surgery.
surgeons who are going and doing palliative care fellowships. We had an OBGYN do
Yeah,
it. We had
OBGYN.
people do
Anesthesia.
gastroenterology, pulmonary critical care, renal, so that these people can become specialists, but like kind of like hyper specialized, and then go back to their other specialty and sort of help disseminate and become the people that live at the intersection of our two fields.
absolutely. Wow. And it also, I think it sounds like it teaches all physicians or paraphysicians how to care better for patients and make it a more personal kind of interaction
Yeah.
rather than you're in the ICU and you know how that can be, or there are definitely a chance to have a deeper relationship with your patient at any time frame that you interact with them, which
That's
I think
right.
is important.
Yeah, and then when I was working as just an internal medicine physician back in my own country, but I was not feeling. I mean, I was doing a lot of medical intervention, but it was not fulfilling because I didn't know actually what the patient wants. Is it the right thing to do? I was just doing it. But now I know how to explore what they want, what make most sense. And then what I do right now, I am confident that this is going to help the patient because I know what they want. And then also we have so many toolbox. I think Dr. Levy, you said there's nothing we can do. There is such a moment, in this, like a terminal condition, but we still have a lot of tools that we, things that we can provide. So I never have to say, I'm sorry, there's nothing I can do. I never have to say it. And then that's so fulfilling, and also I feel very privileged to be in this field and then to be able to help navigate this very, very difficult moment in their life.
I understand.
Yeah.
Well, I think what we'd like to do also maybe on the website is, I think I'll have to go to the National Palliative Care Group and try to list all of the states that at least have palliative care available, to make sure that if people are in a situation and they don't know where to go, that there's a listing for them to be able to contact.
There's a website called, what is it, Takeshi? Getpalliativecare.org. And then it's run by CAPC, the CAPC, which is
CAPC.
to advance palliative care. Full disclosure, it's part of our department, so those are our problems.
Okay.
And they also actually have for the United States, they have what they call the palliative care report card. And it goes state by state and rates sort of access to palliative care. I think they last did it in 2020-ish, or a couple, maybe 2 years ago, 3 years ago.
So for medical professional, I think there is Fast Fact.
Oh yeah, for
Was
like,
it a Fast Fact? Yeah, for that.
Yeah, Fast Facts is for medical folks to look stuff up.
Fix, yeah.
CAPC also has modules for anyone to learn some of the palliative care stuff. They're quite good. And you can get like CME and maintenance of certification points and stuff like that for doing it.
Okay, so list some things that are professional and some that are more for lay people.
Yeah.
Well, this has been terrific. This has been very informative. I think the last comments about being able to offer people something, whether at whatever level they're at, is
so actually palliative care is getting more popular, interestingly, among also residents. So I see the the applicants becoming more. I don't think I'll be able to get into palliative care fellowship now.
Getting competitive, yeah.
Becoming very. I heard that it was fourth most popular specialty among internal medicine specialty or something like that. So it's becoming more popular. I think it's because it's appealing to the young people who's been feeling, what I'm doing. I mean, I went to this medical school, to help people, but some people realize that they might not be necessarily helping people with this complex medical, intervention and then complex situation. And then they see the palliative care as pretty appealing.
Well, thank you. Thank you both very much. It's been very informative. It's really nice that you took the time to be able to offer this to people that are going to be in need of this and want to know what it is that they're going to get. So thank you.